So I wanted to keep today a bit casual, and I sort of wanted to take advantage of the GCI and just take the time to basically tell you about all of my problems and see if you guys have any solutions for me, or if we can partner up and sort of tackle this disease together. So Stephanie says I will be speaking first, and it'll be sort of this very broad overview, nothing too nitty gritty. And then Emily will be talking about one specific project that was recently presented at the IGCS, and then we'll open the floor up to questions. So we're going to talk about vulvar cancer. It is quite a sensitive topic, but really important disease for patients. And I always put in some sort of themes for these presentations. So the theme today is British Columbian mountains. So if you start to drift off, you can try to figure out where all these mountains in British Columbia are. Although I think I have most of them labeled, so maybe not too much fun. But okay, so there we go. Slides advancing. Okay, so yeah, I'm just going to give you an overview of myself, an overview of the research program, and then I will pass the buck along to Dr. Thompson. So as mentioned, I'm an anatomical pathologist. So I work at Vancouver General Hospital in British Columbia, and so we serve a population of 5.1 million individuals. And I'm situated in one of 7 health authorities. So that's Vancouver Coastal Health, which has a catchment population of 1.2 million people. So this is where I work, Vancouver General Hospital. We process 60,000 specimens every year, and most of these are actually complex specimens and complex cancer patients that have been referred in from around the province. We have a team of 20 pathologists, sort of a mixture of full-time pathologists, part-time pathologists, subspecialist pathologists, as well as general pathologists. And we have 3 gynecologic subspecialty pathologists, although it's kind of ranged from 1 to 3 in the last a couple of years. And we have 8 gynecologic oncologic surgeons, and we have 20 to 25 anatomical pathology residents. So this is all just to say that this is an incredibly busy service that we have here at VGH. As being part of VGH, and part of, as you guys all know, the Gynecologic Research Program. So I am part of this overarching umbrella of OVCare and GPEC and of course the GCI. And I have been exceptionally busy with lots of different projects, but I thought, today we'll just focus on vulvar cancer. So what is vulvar cancer? So vulvar cancer, having gone through many, many years of med school, if you're medical trained, you know this already. So the vulva comprises of the skin and structures around the female external genital tract. So what that includes is the labia minora, the labia majora, the clitoris, and the accessory glands. So that's Bartholin's gland and Skene's gland. And it is quite a sensitive site for patients, as well as even a sensitive site, I think, to people socially and culturally. So vulvar cancer is actually a very rare disease. So in the context of all gynecologic malignancies, it really only makes up 3% of the total. And so what that usually means is vulva cancer doesn't get a lot of attention, and it's not infrequent that vulvar cancer sort of gets pushed aside or overshadowed by more common cancers. And that really leads to, the title of the talk. Vulvar cancer is very often called the Cinderella of gynecologic oncology, or the forgotten woman's cancer, the orphan disease, because there really isn't a lot of attention paid to the disease, and not a lot of interest from a donor or philanthropic funding perspective. So vulvar cancer is rare, as I mentioned to you. It has an incidence of 2.6 in 100,000 in Canada. So that equates to about 300 to 400 women every year in Canada that are diagnosed with vulvar cancer. And Canada actually has one of the highest incidences of vulvar cancer in the entire world. We actually rank 5th out of 185 countries as listed by the World Health Organization. So I'm going to give you a brief, sort of a brief context, a sort of overarching context, because there's a lot of nitty gritty. But I think in order to sort of understand what the problems are and to understand what Emily is going to talk to you about, vulvar cancer is really formed by two different pathways. So it's either driven by human papilloma virus infection or it occurs independently of human papilloma virus infection. And the most common cancer type that we see is squamous cell carcinoma. So really that is sort of the focus of the research program, has been largely on vulvar squamous cell carcinoma, although we have done some work in sarcomas and melanomas and other rare cancers. And the other thing to sort of keep in mind, so there is, the cancer, which is the invasive squamous cell carcinoma, as well as a precancerous counterpart. And the precancers have some very unique names. And I'll just draw your attention to the HPV independent squamous cell carcinomas, because those are the more aggressive cancers for patients. And their precursor lesions are given a variety of names. So devil and VAD. So this is differentiated exophytic vulvar intraepithelial lesion, or vulvar acanthosis with altered differentiation, and differentiated vulvar intraepithelial neoplasia. So sort of a variety of morphologic appearances that define these precancers, which can eventually lead into the invasive counterpart or squamous cell carcinoma. So why even study vulvar cancer? And this is where I'm going to spend some time telling you about the problems and sort of picking your brains if you've got some feedback and ideas. So I think about vulvar cancer as sort of three prongs. And the reason why we should study vulvar cancer really falls into three broad categories. And the first is really the clinical need. So we're going to start there. And, I've shown this case before, but I think it's a really important clinical case. And I'm pretty sure that pathologists and oncologists all across Canada will have encountered a very similar case in their clinical practice. So this is an 83-year-old woman who presents to her gynecologist because she has a red, scaly sort of plaque on the vulva, and she goes and she gets it biopsied. And this is what it looks like under the microscope. So as a pathologist, this is what I do every day. We look under the microscope and try to figure out what is going on. And so the diagnosis comes as sort of a reactive lesion. There's no neoplasia, there's no cancer. At least according to the morphologic appearance. And 10 months later, it gets biopsied again. The histologic features are a little bit more exuberant, but even so, it still gets a diagnosis that's kind of nonspecific, no neoplasia, no cancer. And then the gynecologist obviously is getting really nervous because 2 months later, it gets biopsied again, and this time at two different sites. And again, the diagnosis comes back as benign, no cancer, no malignancy. And so this patient has this lesion that just is growing and growing, and there's no diagnosis of precancer. 7 months later, so now we're almost 2 years out, and the gynecologist is getting really, really nervous because now the gynecologist takes 4 different biopsies, and 2 of those diagnoses are again given a sort of reactive benign diagnosis, and then 2 are actually given a diagnosis of a precancer. So finally, the patient actually goes on and gets a resection, and it shows invasive squamous cell carcinoma, which I think is on the next slide. But I did want to emphasize that, this is not an uncommon thing for patients to have multiple biopsies that are just never picked up. And these are 3 different patients from, our institutional archives that had 3 biopsies, 4 biopsies over a span of 1 to 2 years, and then nothing is done until the patient gets an outright diagnosis of invasive squamous cell carcinoma. So in terms of clinical impact for patients, it really is quite substantial. Surgery is the mainstay of treatment because radiation and chemotherapy and adjuvant therapies generally are not as effective. But the vulva, is a really important anatomical site because it's a sensitive site, but also because it is closely associated with the urethra as well as the anal sphincter. And so surgeries can be really quite morbid and uncomfortable for patients, and it can lead to urinary and fecal incontinence. The 5-year survival for patients with vulvar cancer is 70%, and for distant disease, it drops down to 19%. And the other issue with this disease is that 1/3 of patients will recur. And what that means is patients will get repeated surgeries, which then compounds the physical and the psychosocial morbidity that comes along with the disease. And with multiple disease recurrences, the survival drops to 14% over 5 years. So that's one big issue that vulvar cancer faces. And the second one is the diagnostic need. And this is something that is important to me because I am effectively a diagnostician, and this is what we deal with every day. And I don't think I have to say all too much except to bring you back to the first case and say, look how difficult it was to come down with a diagnosis of precancer. And it's not that pathologists are, it's not that you're a poor pathologist, it's just the diagnosis is so incredibly difficult, and it looks like so many benign things, like fungal infections can look very, very similar under the microscope. So, do we agree on what the diagnosis of precancer is? No, we rarely ever agree. It's actually one of the entities with the poorest inter-observer agreement in probably all of gynecologic pathology. In a study by Brigham and Women's Hospital, we're actually, some of the pioneers that first really brought attention to vulvar cancer precursors, even they don't agree. And only 17% of cases will they agree if something is cancer or not precancerous, which is really quite astonishing because they're the ones that actually were like the pioneers in this area. And there's a really interesting study from New Zealand that says, if you go back and you look at patients with vulvar squamous cell carcinoma and you pull up all those previous biopsies, about 77% of them will have a preceding biopsy with precancerous changes, but they're just not diagnosed or they're just overlooked. So all of this means is that, we're delaying treatment for patients, and this is resulting in more morbid surgeries and poorer outcomes for patients with vulvar cancer. And the last thing I think, which is important, is the need for equity. So as I mentioned to you, vulvar cancer is the rare cancer. And with that, it's really hard to get funding for vulvar cancer. And I know that from personal experience. And part of it is, there isn't a lot of patient advocacy because it's an uncomfortable disease. Patients don't really, want to be forthcoming or very public about it, nor advocate for themselves. And there's a lack of philanthropic interest. And, contrary to what maybe people think about, is there are cancers that are sort of popular or they have, a presence and attention. But vulvar cancer is not one of them. They're really not in the spotlight, and they're very often overshadowed by everything else that's going on. And if you dig into the literature, you're only going to find about 20 studies or so that have really used advanced omics-based strategies to look at this. And you can compare this to, ovarian cancer and endometrial cancer. They've got like huge cohorts, they've got the TCGA and all these omics-based studies, but it's just not something that you see in this disease. And there are no targeted therapeutic opportunities. Really, a lot of it just comes down to surgery. And, there's no PARP inhibitors. There's no immune checkpoint inhibitors for this disease. And so this is just to show you the 2017 NIH and DoD funding for cancers, and all, if there's actually a longer list that I had, but it wouldn't fit on the screen. And even if you took a magnifying glass, you still couldn't find where vulvar cancer fits on the list of all the cancers that are funded by the NIH and DoD. So that brings us to, I've told you all my problems, so now I'm going to tell you about what we're trying to do. So our research program is multifold. I'm just going to go into this in a little bit more detail. So one of the biggest problems that we have is the poor detection of cancer precursors. So what are we trying to do? So we're trying to develop assays that we can use as pathologists to better pick up whether a lesion is cancerous or not precancerous. So that's usually an immunohistochemical or an ISH-based assay. So we're looking for protein and RNA biomarkers that we can see that will help us with the diagnosis. The second one is, to have a prognostic tool. Unlike many other cancers, there is really no prognostication strategy. I mean, HPV is sort of becoming the first prognostic stratifier that's sort of gaining momentum and getting published into some international guidelines. But, again, if you compare yourself to endometrial cancer that's got, a good prognostication model, and even for ovarian cancers that have good molecularly defined entities, there really isn't the same thing in vulvar cancer. And so we're trying to work towards getting a better prognostication model. Maybe it's P16, maybe it's P53, but maybe it's even more than that. But nobody has really comprehensively looked. The other is, of course, the limited treatment modalities. And one of the most interesting findings, well, at least I think, that Emily is going to talk to you about, is that we found that a lot of times these patients with vulvar cancer actually have cells around the cancer that have p53 mutations and that you can't see. So if you just look under the microscope, you can't actually see it, but you can see it with immunohistochemistry. So for many years, we think a lot of these patients will have this sort of field of dysplasia that wasn't given any attention. But Emily will talk to you about that. And, it is promising because it's got some funding from the GCI to go on for a local clinical trial as well as with international collaborators. And I think Dr. Amy Jamieson says that it's going to be put in front of the CCTG, which is the Canadian Clinical Trials Group next week. So a lot of momentum, which is super exciting. And then, poor surveillance tools actually, I think, is a mirror to the poor detection. You just can't, you can't detect when the cancer is coming. You can't detect when the cancer is coming back. So again, it's biomarker discovery and then looking for different tools beyond biopsy that will pick up a cancer recurrence. And I think, of course, overall, we just need to look at this disease better and get a better understanding of the disease biology. So I'm going to pass this along to Dr. Thompson, and then, and thank, of course, the rest of the group. This group has actually grown that I need to add photos in here, but I'm going to pass this along to Emily.
Well, as Dr. Hoang mentioned, I'll be presenting a project of ours today. I'm really delighted to be speaking to this. This presentation was originally given virtually in Rome in the summer of 2021, and I'm really happy to be for the chance for a replay for the home team. I'll be speaking about the prognostic significance of these fields of dysplasia in organ confined p53 abnormal vulvar squamous cell carcinoma. As an anchoring framework, I like to think of this topic in terms of the relative importance of morphology, margin status, and molecular or etiologic underpinnings for vulvar squamous neoplasia. So as Dr. Hoang already mentioned, vulvar squamous cell carcinoma can be divided into two etiologic subtypes, HPV associated and non-HPV associated, or HPV independent. And in fact, within the subset of HPV independent cancers, we have p53 abnormal cancers, and we have p53 abnormal HPV independent cancers, and then we have the p53 wild type cancers. And this is important because the p53 mutated cancers have significantly worse outcomes, as demonstrated by our colleagues in the Netherlands, most recently in this paper. And this framework, at least the framework of HPV versus non-HPV associated, has been integrated into the most recent edition of the WHO book for female genital tumors. And that's for both in situ and invasive disease. Pathologists are tasked with articulating whether the cancer or precancer is HPV associated or not, if the facilities exist to do so. Updated ICCR reporting guidelines now recommend that, or suggest that margin status be recorded if possible, and that p53 IHC can be a useful adjunct in this setting. But treatment guidelines don't yet address the management of margins involved by these high molecular risk pre-invasive lesions. As Dr. Hoang has said, these pre-invasive lesions, these HPV-independent pre-invasive lesions, are extremely diagnostically challenging for pathologists. Some say they are among the most challenging lesions that pathologists evaluate. This is the sort of sentinel paper that described one such of these manifestations, DVIN, which Dr. Hoang also mentioned, and the the emphasis here is on morphology. We see elongation of Ricci ridges and fusion of those as of the papillae, as well as acanthosis, which is thickening of the epithelium, and parakeratosis. It's perhaps most importantly, or very much emphasizes this basal atypia, which is, you see here, I'm not sure if you guys can see my cursor, but on the top right, black and white image here, pictomicrograph. And Yang and Hart also astutely noted that these lesions, many of them did exhibit at very high levels of expression of P53 immunohistochemistry. We've known for some time, by way of background, it used to be the case that that vulvar squamous cell carcinomas were treated with a very radical excision, a butterfly excision, which consisted of the vulva and adjacent nodes, as I understand it. And there was a transition in the 1990s to less radical surgery. And we have understood for some time that has had clinical implications in terms of increased recurrence risk. I'd like to draw your attention to a study performed by our group, McAlpine and colleagues, and they looked at outcomes for patients treated before 1995 versus those treated after 1995 when stratified by HPV status. So on the right is a Kaplan-Meier graph, which depicts disease-specific survival, and the unhashed lines, the solid lines, those are patients treated before 1995, whereas the hashed lines represent patients treated afterwards when surgeons began offering more or less radical excisions. And what we see is that the HPV associated cancers in blue and the HPV independent cancers, the majority of which are P53 mutated, before 1995, equivalent outcomes were seen in both patient groups. But after 1995, we see a significant widening and worsening of outcomes for patients with HPV independent cancers. So that's why this work is worth doing, why it matters. And so for this study, our hypothesis was the presence of P53 mutated in situ lesions at a surgical margin of a vulvectomy specimen excised for invasive vulvar squamous cell carcinoma would be associated with an increased risk of recurrence. Objectives were to assess the clinical significance of in situ margin status in patients with organ-confined invasive disease, and to define the clinical significance of margins positive for DVIN, so the morphologic manifestation of an in situ margin positive case, versus these P53 abnormal lesions, which with insufficient morphologic features of DVIN. I'm just going to backtrack a moment, and you're going to notice, perhaps you'll notice that Dr. Hoang mentioned the different morphologic manifestations, the devil, VAD, DVIN. Here, I'm just talking about in situ neoplasia that's visible for pathologists or versus not, which is too morphologically subtle for us to pick out. We selected a cohort in our institutional archives that were treated after 1995. We restricted that cohort to patients with first presentation organ confined disease, which was completely excised by morphologic assessment. We we characterized those cancers using P16 and P53 immunohistochemistry to identify patients with P53 abnormal HPV independent cancers, and then we stained up to 3 margin blocks with P53 to evaluate margin status. We identified 57 patients in our institutional archive that were suitable for inclusion to this study. Of those, 16 had morphologic DVIN on a margin, and 11 had a P53 abnormal in situ lesion extending to a margin without features that were sufficient for a DVIN diagnosis. There were 30 cases where there was no morphologic or molecular abnormality present at the surgical margin. This is an example of some of the cases where we found occult, P53 staining extending to a margin. And when I say occult, I mean, we weren't expecting it. I mentioned about how, the characteristic features of DVIN are, acanthosis, parakeratosis, elongation and fusion of papillary reedy ridges, and then this, basal atypia. But here in these cases, I mean, maybe top right was probably, soft DVIN. You do see some acanthosis and some elongation of reedy ridges, fusion if you're looking carefully. But the other cases here, we don't see that. They're atrophic. We don't see thickening of the epithelium. In many cases, we don't see, papillae or reedy ridges at all. So these were a surprise to us. And indeed, in our, initial cohort, there were 30% of cases that were reported as clear of in situ disease at a margin. In fact, had these lesions at the margin. So this is our cohort. Apologies, I know it's always hard to see a table on a screen like this, but as I mentioned, we had these 57 cases included. This is just to make the point that there were no statistically significant differences in the three subsets of patients by age at presentation, number of years of follow-up, or tumor size. But we did see a significant difference in terms of the number of patients who experienced disease recurrence. And so positive in situ margin status, whether it was DVIN or whether it was P53 mutation status positive by IHC, was associated with a 66.7% rate of risk of recurrence versus 33.3 in those who were margin clear by morphologic and molecular assessment. So we talk about recurrences. It's kind of interesting to look at what those recurrences comprised of. And you can see that for in situ, so non-invasive disease, the rates were roughly similar. But for locally invasive recurrences, we saw double the rates of recurrence in patients who had in situ margin disease in that original bulvectomy specimen. For nodal recurrence, the rates were 3 times what was observed in patients with who had clear margins by IHC, and that with a trend towards statistical significance. It's a Kaplan-Meier outcome analysis graph segregating these 3 groups. In light blue, we have patients that were with clear margins by IHC assessment and morphologic assessment. In dark red, we have patients who are morphologic, have in situ margin positive disease by morphology. And in dark green, we have those patients that were occults that we were only able to recognize with the use of P53 IHC. And for recurrence-free survival, we saw a significant difference in these patient subsets. In terms of overall survival, the difference wasn't statistically significant, but that makes sense considering that the age and status of the patients at presentation. So the take-home points are that in situ margin positive status for P53 abnormal HPV independent cancers is associated with recurrence irrespective of what the margins look like absent IHC assessment. And therefore, we believe that P53 immunohistochemistry is critical for accurate assessment of margins for patients with HPV independent cancers. And this justifies the need to evaluate biologically informed treatment approaches for this cancer in prospective interventional studies. Enter STRIVE, which is a locally led, multi-center randomized interventional study, which will examine targeted interventions for patients by HPV and P53 status. Of course, we have our local team as well as collaborators across Australia and New Zealand and now the UK. I'd like to take this chance to thank my many collaborators and be delighted to take any questions at this time.